Thank you to the committee for this opportunity. My name is Teresa Dionisio. I'm an interventional radiologist, and it was asked me to talk about the clinical evaluation and the guidelines for the treatment of acute mesenteric ischemia. So these are our goals for this morning: to introduce the clinical evaluation of these patients, to describe the impact of the biomarkers, and to discuss the current management guidelines. We all know that acute mesenteric ischemia can be occlusive and non-occlusive. Actually, it is an umbrella term encompassing a group of diseases characterized by an interruption in the blood flow to different portions of the bowel. It can cause ischemia and secondary inflammatory changes. It can be caused by arterial embolism in the most of the cases, but also by arterial thrombosis and venous thrombosis. Its overall incidence is very low, but increases with age, and despite it is a rare cause of abdominal pain, it is indeed a common cause of emergent bowel resection, and the only way to have a better outcome is to have a prompt diagnosis and intervention. There are no specific signs or symptoms of acute mesenteric ischemia. These patients usually present with severe abdominal pain that is out of proportion to physical signs. This onset can also help us to think about the cause. We have a brute onset in the case of embolism and a slower onset in the case of thrombosis and acute and chronic cases. This can be accompanied by nausea, vomiting, diarrhea, and bloody stools. And some of these patients have also associated history of atrial fibrillation, heart failure, and chronic ischemia. Signs of peritonitis can appear in late ischemia because of bowel necrosis, and all we want is to have a diagnosis before it happened. There are non-available specific laboratory tests to acute mesenteric ischemia as well. We use some biomarkers on emergency. Some of them can help us to figure out there is acidosis, for example, but they are non-specific and should not be used for diagnosis. For example, raised lactate can appear in a late phase of the ischemia. It means irreversible ischemia, but if we have normal lactate level, we cannot exclude acute mesenteric ischemia, so this should not be used for diagnosis. The same for leukocytes and amylase and so on. Hopefully, there are some promising biomarkers on the way. Maybe we can use them in the near future, but for now, there are none available. And the best way to have a diagnosis is with CTA. The treatment approach will depend on the cause, the time when you get a diagnosis, and the extension of the disease at that moment. The surgery has been the gold standard for several years, but now we have some endovascular techniques that are having an increasing role. The goals of these interventions are always revascularized occlusion to preserve bowel and remove the non-viable bowel. We'll see this later in detail with my colleagues. It's just one warm-up. So the first line should always be the medical treatment with fluid resuscitation, the correction of the electrolyte imbalance, nasogastric tube, antibiotics, and anticoagulation. And after that, we can choose between some surgical and endovascular options depending on the cause and stage of the disease. This is an algorithm proposed in the last guidelines of the World Society of Emergency Surgery. So if we have a patient with a suspicion of acute mesenteric ischemia, look for risk factors. You can ask for some lab tests that can help you to know if there is acidosis and organ failure, and start immediately fluid resuscitation, antibiotics, nasogastric tube position, and correction of the electrolyte abnormalities. Okay, the patient goes to CTA, and if we get the diagnosis, you confirm it, this patient should be assessed by a multidisciplinary team. There are some different possibilities, some different scenarios here, but main branches are: if you have a hemodynamically abnormal patient, maybe with signs of peritonitis, okay, we should take him to surgery to damage control, and then choose between a open or endovascular revascularization. In the other hand, if you have a patient that is hemodynamically normal with no signs of peritonitis, think about endovascular options as a first-line treatment. Always remember that these patients need a close monitoring after that, because sometimes we can see signs of peritonitis and a need of surgery even after a successful revascularization. So, to conclude, this is still difficult to get early diagnosis in the reversible stage of the disease. That is an emergency. So the most important message here is to have a high index of suspicion based on the combination of a history of abrupt onset of abdominal pain, acidosis, and organ failure. This clinical scenario should prompt a rapid CTA, and in parallel with the rapid resuscitation and the careful assessment of CTA, the patient should be explored to assess bowel viability, reestablish the vascular flow, and resect the non-viable bowel. Thank you.